I'll turn it over to him.
All right. First of all, thanks for inviting me, Cliff, and thanks everybody for joining in. I am a neurogastroenterologist, and essentially what it means is I'm a motility expert of the GI tract. And as you know, a lot of our kids that have muscular dystrophies or myopathies have associated GI disorders or nutritional issues that I see here in my clinic. So that's my kind of background. I've been a gastroenterologist almost for 19, 20 years now. And like I said before, I did my residency at Buffalo, New York, and I moved to Cincinnati here to do my fellowship and have stayed here since. I've joined the faculty here. So that's my background, and the reason I'm interested in this group of disorders is because, like I said, there is a huge overlap between the patients we see with GI motility disorders and muscular disorders. So what I'd like to do is I went ahead and asked Cliff to give me some common, I guess, issues that you would like to discuss and what have been discussed on your, I guess, your website or your blog. And he was kind enough to send me a list. And what I'd like to do is to kind of go over the list with you all. I'll just highlight the issues, and then we'll talk about each one of those. So the first one I'd like to talk about is how is the GI tract affected in children with Nemaline myopathies. And then I'll go on to talk about aspiration risk. We'll talk about how you differentiate between what is vomiting and what is reflux. And we talk a little bit about testing for these two conditions, vomiting and reflux, and the role of proton pump inhibitors or acid suppressants like the Nexiums, the Prevacid, etc. We'll also touch upon fundoplication, the pros and cons of fundoplication, the testing you need to do before you even consider fundoplication. If we have time, we'll talk about slow gastric emptying, and then kind of end with feeding tubes, G-tubes, GJ tubes, which one's appropriate, when, what kind of regimen, when do you use a pump, when do you do bolus feeds, when do you do continuous, what kind of formula you use, how do you monitor nutrition, etc. I know it's kind of a pretty long list, but we'll try to cover as much as we can, if that's okay with everybody.
Yes.
Sounds good. Sounds great.
All right, so let's start by how is the GI tract affected in Nemaline myopathy. So as you all know very well, that the myopathy really involves the skeletal muscle in your body. So as you know, we have three types of muscles in our body. The skeletal muscle is what's on the outside. The second group of muscles is called smooth muscle, which is primarily your GI tract. The third group of muscles is the cardiac muscle. So there's three types of muscles. In Nemaline myopathy, as far as we know so far, it's only the skeletal muscle that is involved. Now, you would ask, I just said that the GI tract was mostly smooth muscle, but there are both ends, the beginning, which is the pharynx or the back of your throat, as well as the upper part of your swallowing tube or the esophagus, does have skeletal muscle. Similarly, the very end, the anal sphincters are made up of skeletal muscles. The rest of the GI tract is all smooth muscle. So theoretically, it's really just the ends of the GI tract that are affected in Nemaline myopathy. Problem is that, especially the upper end, that area is critical for swallowing and prevention of aspiration. So that's why when children that are more severely involved have weakness of the back of their throats and their swallowing mechanism is not very effective. So when they swallow, some of the food or liquid remains in the back of their throats, and that makes them high risk for aspiration. Or aspiration means, as you know, food or liquids going down your airway tract into your larynx and your trachea, where it shouldn't be. And then you get aspiration, you get pneumonia. And in our children, you know that folks with Nemaline myopathy, they don't have very good respiratory excursions. They have restrictive lung disease. So once they aspirate, they don't have a good cough reflex to actually bring all that stuff back up. So that's why you have to be extremely careful about aspiration in children with Nemaline myopathies. Now, we do have inherent protective reflexes that are built into our system. So when there is aspiration occurring, first of all, there are certain reflexes that will prevent one from food going into the airway or your breathing tube. And one of them is a strong pharyngeal contraction. The back of your throat, when you swallow, squeezes really hard and pushes the entire bolus down into the esophagus, so there's nothing left there. So if that's weak then, and like I said before, if there's still some liquid or food remaining in there, there's always that risk that it may drop into the airways and cause aspiration. Any questions so far?
Not yet.
Okay. So then let's move on to how do you differentiate between vomiting and reflux. So these are really two ends of a spectrum. Reflux is anything coming up from your stomach into your mouth. That's reflux. Vomiting essentially is a type of reflux technically, but the neural pathways that cause vomiting are different. And the biggest differentiating factor clinically that you can see between quote-unquote vomiting and reflux is that vomiting usually is associated with nausea and retching. Reflux is not. Reflux is almost like a passive regurgitation. Okay, so children that have Nemaline myopathy do tend to have higher prevalence of reflux. Again, there is no published data in children, but it's just from experience. Most kids with myopathies are at higher risk for having reflux. Now, remember, we all reflux. We all, after you eat a meal, it comes up. That's normal. But what's not normal is if it comes up, goes into our throat, and then we're not able to effectively clear it because we have weak pharyngeal contractions and therefore aspirate. So that's the problem. So vomiting, like I said, is a complete. Vomiting can be triggered from different sources. Vomiting you could have from children with ear infections. Vomiting could be from headaches, migraine headaches. Vomiting could be from from your middle ear balance. Vomiting could be from kidney infections, urine bladder infections. It could be from several different sources, but reflux is specifically occurring from the stomach into the esophagus, and it's because of neural pathways, nerves that go from the stomach and the esophagus up to the brain. And so it's a very different mechanism for vomiting as opposed to reflux. The reason I bring that up is that it's very critical to differentiate the two because the causes could be different. And when you talk about fundoplication, and we'll talk about that later, you never, ever do a fundoplication surgery on a child that is vomiting. Fundoplication is primarily a surgery that is done mostly for gastroesophageal reflux, which is causing problems, such as in a child with bad aspiration risk. Then you can consider fundoplication. You do not do fundoplication in children that are quote-unquote vomiting. Is everybody okay so far?
Mm-hmm. Yeah. You might be getting to this, but I'm just wondering why do especially young children with Nemaline myopathy tend to vomit so often?
Okay. So, again, is this vomiting you're talking about, or is it really reflux you're talking about? Vomiting,
I think it's real vomiting. During feedings or right after feedings.
Okay. So we'll get to that. So the vomiting, let's talk about that now. So the vomiting, whenever this is normal physiology. Whenever you swallow and food goes down into your esophagus, there is what we call peristalsis, which is a series of contractions, ring-like contractions, that start in the upper esophagus and move down the esophagus, pushing the food bolus or the liquid bolus down into the stomach. So it's not just by gravity that food goes down the esophagus. There's actual contraction, a ring of contraction that moves down from the top to the bottom, that clears the esophagus of all the food. Now, remember I said the very top one-third of the esophagus is made up of skeletal muscle. So even after you swallow, if that part of the esophagus is affected by Nemaline myopathy, that peristalsis is abnormal in that top part of the esophagus. So you get a feeling as though food is getting stuck in the top part of your esophagus, and the natural reflex is to vomit or gag and bring it up and throw it up. That makes sense?
Mm-hmm.
Yes.
So that is essentially why kids with Nemaline myopathy will have vomiting.
What about those kids that are G-tube fed? They tend to vomit a lot too.
Good question. Now remember, we always have oral secretions. We always have saliva production, and quite a bit. If you measure a 24-hour output of saliva, you'll be surprised at the amount. So what typically happens is, what do? You're always swallowing it, and you're not. If that process of swallowing is impeded in any way, those are the kids that will start drooling and their saliva coming out and falling out of their mouth. So if you have problems with swallowing, you cannot even completely swallow your saliva well. Even if you are able to swallow the saliva, it goes into your top of that affected esophagus and gets stuck there, and then the same thing, it triggers the same kind of gagging and vomiting, even though these children are being fed through the G-tube. Does that help?
That makes a lot of sense to me.
Okay. Now, the other thing is those children that are getting G-tube fed, like I said, everybody refluxes. So some of that formula comes up, shoots up the esophagus, and if it reaches the top part of their esophagus, which is affected, again, the same thing. You cannot clear what's in that top part of the esophagus by on one single swallow like you and I can. Some of these children...
So you're saying as it's going in through the G-tube, it's traveling up?
No. Usually when the stomach is full of formula, what happens is the lower esophageal sphincter relaxes. It does that in everybody. It relaxes more often when the stomach has food in it or liquid in it. So when you do that, then naturally some of the formula, especially when the kids are laying on their backs, comes up all the way to the top of the esophagus, and then they're unable to clear it back down.
Okay.
So the problem could be both from just natural salivary secretions that they cannot clear, as well as from formula coming up into the esophagus in kids that are being fed through the G-tube. Okay?
Yes.
Does that make sense?
Yeah.
All right. So now, vomiting, like I said, is completely different. So how do you distinguish between the two? Well, clinically, first of all, you should have the basic knowledge of why a child, is vomiting. Like I said, you need to know that the top part of the esophagus has skeletal muscle, which is affected, and that's why they're having all these problems. So when you do an upper GI contrast study, also called a barium swallow study by some people, it's essentially the kids will drink a barium, and you can see on the X-ray video how effective is the pharyngeal clearance. In other words, when the child swallows the barium, you can clearly see if the entire barium bolus goes down the esophagus, or is it a weak contraction and part of it stays back in the pharynx, making the child at risk for aspiration. What you can also see in that study is how the top part of the esophagus, does that clear off the barium quickly, or does barium stick there for a while and causes the kid to gag and retch. So that's one study that you could potentially do to kind of document what we were just talking about. I typically don't necessarily do that because I know that's what the cause is. There's no point in putting a kid through this test and radiation, but there are some parents who will insist on having a documented kind of objective evidence to show that that's what it is, and that's when we would do an upper GI study. Any questions so far?
No.
Anybody okay?
I have
Go
a
ahead.
question. This is Patty Mitchell from Chicago. I seem to notice that when the kids at school get stomach flu, my daughter never really throws up. She is more kind of gets the runs. I know that's a lot of information, but do you notice that with kids that have myopathies? Is there a weakness that makes them really unable to throw up? Even though, they can throw up potentially if they have too much food in, but when they get something like a stomach flu, do they tend to not expel by vomiting?
That's an excellent question, Patty. Yes, that is true, because remember, when you're vomiting, one of the muscles that is having a huge effect is your abdominal muscles and your diaphragm. And what type of muscle is that? Skeletal. So those are involved in Nemaline myopathy as well. In fact, in most myopathies. So they cannot, even though they are feeling nauseous, they want to throw up, they don't have that ability to squeeze the diaphragmatic muscles, the abdominal muscles, strong enough to increase the intra-abdominal pressure to shoot that thing out of their mouths.
That's helpful, because that was always just something I've been noticing and I thought was the case, but I wasn't sure. So thank you.
Yeah. Sure.
I got sort of the opposite question.
Uh-huh.
My son seems to be able to throw up on demand. Like he can, like if he's upset, he will throw up. Like he can force himself to throw up. He doesn't stick his finger down his throat. He could just bring it up.
Mm-hmm.
Is it because is that through a myopathy that he's able to throw up so easily?
No, and I'm glad you. That's a great question, and I'm glad you brought it up. I wasn't going to touch upon it, but I've been seeing this more and more commonly in children with myopathy. So that's a condition called rumination, and it's in the same spectrum as I was talking about earlier of vomiting and reflux. So rumination is obviously derived from the word ruminant, which are cows, and where they typically, as you can see, these cows when they're in the farm, they just kind of chew the cud, swallow it down, and then they'll just be chewing all the time, and that's because that food is coming up into their mouth. They can actually voluntarily bring that up into their mouth. They chew it again and swallow it again. So that's where this word rumination is derived from. And when it was first described decades ago, it was usually only seen in children that had significant neurodevelopmental issues, and typically in children with cerebral palsy, where they saw this kids multiple times during the day had these effortless kind of episodes where they would regurgitate and bring stuff into their mouth. Some would come out of their mouth, they would just spit it out or swallow it. And this would happen several times during the day, and even when they were not eating, this would happen. So this is called rumination, and it's a kind of a distinct disorder. It's clinically pretty distinct, and like I said, it typically occurs multiple times, and it's effortless. There's no retching involved. They can just bring it up, and then they kind of swallow. Now, the reason they do that is because they're compressing their abdominal musculature and bringing it up. Now, remember I said that a lot of the myopathy kids are not able to squeeze the muscles really hard to be able to do the rumination thing. But over time, as the myopathy progresses, then that kids that were ruminating before, that rumination kind of eases away. And that's because they just cannot generate enough pressure to bring things back up.
Mm-hmm.
Over time, we've also seen rumination in completely neurodevelopmentally normal children, typically girls in the pre-adolescent, adolescent age groups who are undergoing a lot of stress. So some behavioral psychologists are of the opinion that there is a strong behavioral component to this as well. And some of them even think that this is kind of a self-stimulatory behavior. So that's that whole other issue of rumination. I'm glad you brought that up. Does that kind of make sense, or is?
Yeah, it makes sense. I think with my son, it's almost entirely behavioral. He does it when when he's upset, or if he wants to get his way.
Mm-hmm. So that's rumination.
Yeah.
Now, we were talking about reflux and the vomiting and how the two conditions are different and how you distinguish one from the other, etc. So then the topic of acid suppressant medications, what we call proton pump inhibitors, or PPIs, which include the Nexiums, the Prevacid, the omeprazoles, etc. Remember, those group of medications, all they do is prevent the stomach from producing acid. That's all that they do. They do not stop the actual physical movement of the gastric contents to come up into the esophagus. Is that clear?
Yeah.
So when you do, oh well, the child has reflux, let's give him some acid reflux medicine. Well, it's not going to stop the stuff from coming up into his esophagus. All it's going to do is reduce the stomach acid from being produced. So whatever comes up into the esophagus is not acidic, so therefore it's not going to burn the lining of the esophagus. So it's more of a preventative thing from preventing the esophageal lining from getting burnt by the acid from the stomach. That's all that the proton pump inhibitor will do. It's not going to stop that physical movement. Right?
Mm-hmm.
Questions, anyone?
Is it also inhibiting digestion or
No,
changing digestion? Okay.
No, it's not. What it is doing, and when it first came out, we were using PPI, and actually the use of PPIs in pediatrics climbed significantly, and we were using it. And I can say that now, we were using it inappropriately. And every kid that had belly pain, having a little bit of reflux, a little bit of chest pain, start them on PPI. So there was a lot of PPI use that was going around, and we kind of realized that long-term use of PPI is not safe. So we're now back to square one, where we're actually trying to investigate whether a child truly has reflux and whether a PPI is truly indicated by doing impedance studies, pH probe studies, before we put them on any acid reflux medications. Any other questions so far?
My daughter used to vomit sort of twice daily for this whole last winter. She was vomiting a lot, and now it's been actually a few weeks, and this whole summer it's been sort of once every few weeks, and I'd like to trial her off the PPIs. Do you have advice about how to do that?
Sure. Remember, the one thing about PPI is that if you've been on one of those for a chronic long period of time, meaning months, then you never stop at cold turkey, because remember, these medications are blocking the proton pumps. And as soon as you stop at cold turkey, that block is removed suddenly, and the stomach literally starts churning out all this acid. So you immediately, even if you weren't symptomatic, you will become symptomatic, and you'll say, uh-oh, the kid's not doing well, put him back on the PPI. No, you always wean the PPIs off. So it could be done over a period of 3 to 4 weeks. You slowly, there's no approved kind of protocol for that, but you slowly reduce the medication, the PPI. You could go, if you're on double dose morning and evening, you go to once a day, alternate with once a day, and then you go down, skip a day and go that way, and then you reduce the dose. If you're doing 30 milligrams, you do 15 milligrams, and you gradually get off of it.
Great,
okay?
Thank you.
Now remember, there are other causes of vomiting too, and we said we would talk about slow gastric emptying if and when we get time to it. So you just have to be careful that, it's not just the Nemaline myopathy. Kids with Nemaline myopathy can also get other illnesses which, normally other kids get. So slow gastric emptying is not necessarily a feature of Nemaline myopathy, because remember, the stomach muscle is smooth. It's not a skeletal muscle. But when you get slow gastric emptying, it's usually after a viral infection or even a subclinical infection, and the stomach just slows down and the kid starts to get nausea, epigastric pain, and vomiting, and sometimes they start losing weight as well. And the good news for that is that is typically not long-lasting. Over the course of the ensuing weeks or months, it does tend to get better. And in most kids, by 2 years, that resolves. So that's really not specific for Nemaline myopathy, but kids that have Nemaline myopathy can certainly get that. So if everybody's okay, we can move on to fundoplications.
Sure.
Great.
Okay. So fundoplication, as you know, is a surgery which is done specifically for gastroesophageal reflux disease that is causing problems, not just simple gastroesophageal reflux, which all of us have. If the reflux, like in children with Nemaline myopathy, if they have really bad aspiration risk. If they are literally aspirating everything into their lungs, then you have to be careful, and that's the one condition that one might consider even doing a fundoplication. I'm not a big fan of fundoplication in children with myopathies, and that's only because it's a surgical procedure, number one, even though it's laparoscopically performed by most surgeons these days. It is a surgery that is permanently changing the child's anatomy. So what you do in fundoplication is that you take the top part of the stomach, which is the fundus, and therefore the term fundoplication. What you're doing is you're taking the fundus of the stomach, the dome of the top of the stomach, you actually bring it around the lower end of the swallowing tube or the esophagus, and you stitch it on the other end. Okay? So what you're essentially trying to do is tighten the lower esophageal sphincter so that the stomach contents don't go back up. Now, this is not an all or none phenomenon. It's not like when you do a fundoplication, you completely stop all reflux episodes, because that would be a problem. Then you cannot, whatever you swallow won't go down either. So fundoplication reduces the number of reflux episodes, but it can cause a lot of problems in patients, especially if you haven't ruled out other comorbidities such as a slow gastric emptying. So think about it. If you have a slow stomach emptying, so you're swallowing food, it goes down in your stomach, but it just sits in the stomach because your stomach is slow in emptying. And if the longer it sits in the stomach, the more you're more likely to reflux and bring things up. Now, if you do a fundoplication and you tighten that, what will happen? That reflux mechanism that you had to decompress your stomach is now gone, and you cannot throw it back up. You cannot reflux it. You've tightened that, and then you get complications such as gas bloat and distended stomach and really uncomfortable and pain, and etc. So when you do a fundoplication, you have to be very careful to make sure that the child does not have any other conditions, structural or functional conditions of the GI tract that can make the child worse. The reason I don't like fundoplication is another reason I don't like fundoplication is because there is another alternative to that, and that is GJ tube feeds or NJ tube feeds, where you bypass the stomach and you feed into the intestines directly. So that it doesn't matter that the stomach is slow; you're not feeding into the stomach; you're feeding beyond it into the intestines. That make sense?
Yeah, that makes a lot of sense.
Okay. Now, one of the other complications of fundoplication is even in the hands of the best surgeons, when they do that wrap around the lower end of the esophagus, where they bring that dome of the stomach around the lower end and stitch it, sometimes the vagus nerve, which is coming down from the brain along the esophagus, going down into the stomach and abdomen, that vagus nerve gets entrapped in that wrap. The vagus nerve is extremely important for motility of the stomach and the intestines. If that gets damaged in that surgery, then you have downstream effects where the stomach becomes slow. This is what we call acquired gastroparesis or acquired slow gastric emptying, not very different from the post-infectious slow gastric emptying that we had talked about earlier. Okay?
Can this be corrected by reversing a fundoplication?
No. You typically do. Surgeons will not go back. Well, some of them will, but typically going back to undo the fundoplication is a surgical challenge, and typically people don't like to do that. What they would do then is to endoscopically or with what we call bougies go down and stretch that wrap and try to undo if it's too tight. But that really doesn't address that nerve entrapment, because even when you try to loosen the fundoplication by putting a bougie or something down the esophagus and trying to open it up that way, that sometimes can cause entrapment of the vagus nerve to get even worse, because it's between the outer lining of the esophagus and the diaphragm, so it gets pinched there. So when the vagus nerve gets entrapped or pinched in the fundoplication wrap, you get downstream effects, which is gas, the same delayed gastric emptying, gas bloat. Sometimes you even get rapid gastric emptying and dumping. So those are some of the things that you have to be aware of before you even consider doing a fundoplication. So
I have a question.
Go ahead.
It sounds like the main reason why you do a fundoplication is if you're aspirating your own saliva. But yet...
Well, not saliva, Cliff, because remember, you cannot do anything about that. The fundoplication, all that's doing is preventing the gastric contents from coming up and then aspiration.
Okay, yeah, aspirating the gastric contents.
Correct.
But it seems like fundoplications are recommended almost routinely, and because I see a lot of emails, people saying that they're considering it and that their doctors recommended it. I know doctors recommended it for my son. So why is that?
So, that's a difficult question to answer. But like I said, I've been doing this for 20 years, and I've become less and less of a fan of fundoplications. And I'd rather just do, what we call transpyloric feedings into the intestine rather than putting a kid through fundoplication. So even if the prevalence of complications after fundoplication, even if it's 20% or 2 out of 10 kids, I don't want my child to be that kid. Because
right.
If you've seen one child with complications out of fundoplication, you can make up your mind and you say you never want this ever for your child. They can retch and gag, and they're so uncomfortable. They cannot decompress their stomachs, and because of the gas bloat, because of the fundoplication, then sometimes if the surgeons tightened it too much, then they have problems even swallowing. So the food kind of tends to stick in the lower esophagus and then cannot clear into the esophagus. Some of these kids, they continue to retch and gag and then cause paraesophageal hernias of the stomach because of increased pressure in the stomach. So there's a really nice article which they describe all of these potential complications after fundoplication. Now, the goal, our collective goal for our children with myopathies is really improving quality of life. And if you end up with a child after fundoplication with any of these complications, you're actually ruining or actually worsening their quality of life because of all the retching and gagging that the poor kid does afterwards. I'm not saying that fundoplication should never be done in a child with MIO. That's not what I'm saying. It has to be carefully evaluated, and if there is an easier and simpler way of addressing that, then I would rather do that.
Can I ask a question?
Absolutely.
My son is 2, and he has a G-tube, and they gave him a Nissen. The pH probe was negative, but he was an aspiration risk. But he still vomits daily. He doesn't really retch or gag. They tried to do a looser Nissen on him, and we are going to be checking the status of it to see if it has come undone. I think I remember reading that repeat Nissens aren't necessarily successful.
That's another thing that one of my peeves is when a child comes to me for a second, third, or fourth opinion, and the child has had 3 Nissen fundoplication, and every time they do a Nissen, it just gets unwrapped. What is the body trying to tell you? The body's telling you that they cannot tolerate a Nissen. There's something amiss there. Because Nissens, if they work, they should work the first time. If it's not working, then if you do a second or a third Nissen, it's never going to be. That's not the answer. The body's already telling you that Nissen is not the answer for this child. So a loose Nissen, a lot of people have kind of debated that. Can you do not a tight Nissen, but a loose Nissen, or not a normal Nissen, but a loose Nissen? The thing of it is that it's almost like saying, oh, well, are you half pregnant? Are you, it's just you either do it well or you don't do it. So this loose Nissen is kind of a myth, really. So we're doing a pretty large-scale study here. We have over 200 children that have had fundoplications done, and these aren't children with myopathies. These are children that had, for whatever reason, had a fundoplication wrap done. And we are looking at what is the effectivity of the Nissen in keeping the reflux episodes down over time, and it's pretty good. I mean, kids that have had a Nissen fundoplication on an average will reflux about 10 to 20 times as opposed to 60 or 70 times. So yes, it does reduce the number of reflux episodes, but then that's not the problem. The problem is those complications that fundoplication can potentially cause, which can worsen the quality of life, which is what we're trying not to do. Questions? All right.
Are there different types of fundoplications?
Yeah. So when you talk about a Nissen fundoplication, that's the kind of the classic or the typical fundoplication that they kind of take and do a wrap. Now, sometimes people will do the number of stitches may be less, the number of fold that they take around the esophagus could be thicker, could be smaller. There is what we call a partial wrap, which could be just an anterior wrap, meaning they just stitch the anterior part of the esophagus, not the back. There are others that just do the posterior wrap, not the anterior. And then there's this myth about this loose Nissen, and so there's different types of fundoplications. Nissen is what is classically done in kids, but there's other variations to it. And there's really no data to suggest that, quote-unquote, a loose Nissen or the anterior or the posterior fundoplication, half Nissens, would be helpful. Okay. Now, when your child, going back to, Shannon, was it you that was asking?
Yes, about
the vomiting. So you have to be careful that the vomiting, and we talked about how the vomiting may not have anything to do with the stomach. The vomiting could be just him trying to get his secretions out of the esophagus, or food that's gone down the esophagus and it's just sitting there, or even his secretions. They've not even entered the stomach yet, and he's throwing it up. This is what we call esophageal reflux, meaning it's not gastroesophageal, it's still within the esophagus, and it's coming back up. You with me?
That makes a lot of sense. Yeah, sometimes I think I see that. Yeah, because I see the secretions first. Yeah.
Right, so that's something. So if you have a child that does have a G-tube already and is still vomiting past a Nissen fundoplication, one of the options is to do continuous GJ tube feedings. Is that something that your doctor has discussed with you, Shannon?
He had that GJ originally, and then we did the Nissen after that, and then we went to the G-tube feeding.
Okay. So I personally, like I said, for kids with myopathy, I prefer the GJ tube, and that's one of the reasons why, because the fundoplications, quote-unquote, get undone, or they have problems after that. They have gas bloats and things like that. So I actually, if the kid needs a G-tube, I'd rather prefer just doing a GJ tube. Even in kids that have aspiration, bad aspiration, I would prefer doing GJ tube feeds before doing fundoplication. And again, because fundoplication, as Cliff had mentioned, fundoplication is only reducing the number of reflux episodes, not completely stopping the reflux episode. So even if you have one reflux episode that comes up into your mouth and you're not able to swallow it back down appropriately, you'll get aspiration. Plus, fundoplication does nothing for aspiration from above, meaning when you're swallowing your secretions, etc. Make sense?
Yep.
Yeah.
All right. You need to tell me if there's something that's, doesn't make sense to you, because a lot of the parents they're kind of weary of doing GJ tube feeds. The only reason being that, my child's going to be hooked up to a pump, because the only way you can feed GJ is using a pump. It has to be continuous. But with all the new developments, these pumps have become so small and ambulatory, and you can see kids in the mall in their little strollers with their pump in the back, and they're being fed. Nobody even cares. They're going about their merry way. So really, GJ tubes have really. I'm a big fan of those instead of the fundoplications. That's all I'll say. All right, Shannon, I want you to tell me: is there something that's not?
No, that's exactly. The GJ would really impede his mobility at this point. Just like the backpack would be too heavy, but he kind of scoots around, So we do like real blended food and push it in, in big syringes, and generally it goes fine. But there's that, that time where once a day, or if he gets upset, like Cliff was saying, if he gets upset or gets hurt or something, then he just starts crying and then he vomits. So.
Right. Now, the GJ tube, Shannon, what you could also do is you don't have to do it 24/7. You could do, especially if your child is 2 years old, your daughter is 2 years. You said she's 2 years old?
Our son is 2 years old. Yep.
Your son, sorry. So if he's 2 years old and he's mobile, and then you can certainly do GJ feeds overnight when he's asleep, and give him what we call a window during the day when he's most active, and then hook him up again during the afternoon hours, and then take him off in the evening when you guys are going out. And so you can certainly do that as well. You just have to make sure that at the end of the day he's getting his calories and fluid requirements.
Right.
Okay. All right. Anything else?
Well, if a child like Shannon's son, like she said, was vomiting about once a day, but growing, staying on the growth chart, would you consider that because of the aspiration risk too much, or is that tolerable? I mean, how would you make the judgment about switching to GJ when there are all these other great quality of life benefits, like giving him real food and doing bolus feeds and things like that?
Great question. Now, it's really, if they throw up, honestly, if they throw up once a day and otherwise the kid's fine, has good quality of life, is, gaining weight, etc., I wouldn't really bother about that, because we know children with myopathies do throw up, and we know the reasons why they do that. You just want to make sure that there's no structural problem, or there's no delayed gastric emptying, and that it's not impacting weight or his intake, or the fluid intake is not aspirating. Those are the things that you need to be aware of. Now, aspiration, how would you recognize aspiration? Obviously, if in kids that have a good reflex, cough reflex, they will choke and cough, and like you and I will try to bring it out. There are times when kids can get silent aspiration, and that's the scariest part, where they don't have the ability to cough strong enough, especially when they have weak muscles and have restrictive lung disease. They don't have that ability to cough up the stuff that's going down their airway. So those are the kids that will have what we call silent aspiration. Those kids will typically sound wet, and you know what I'm talking about when kids are kind of have this wet kind of a breathing quality, where it's almost like the air that they're breathing in and out is going through this bubbles of water. And when they're swallowing, when they're talking, it sounds kind of, they have this wet quality to their voice. I don't know if any of your kids have that. But that's usually in the later stages, when the myopathy is severe enough that the back of the throat, the pharynx, is not clearing the secretions, and they just tend to sit there, and the kids are talking or breathing, and just gives this wet kind of a gurgling quality to their breathing and swallowing. So those are some of the ways that you can suspect aspiration. Now, some kids that have silent aspiration, they may just have a low-grade fever, and that might just be their manifestation. That's it. That would be the only presentation, that they have a low-grade fever all the time, and you've done all the ear checks and the urine checks, and there's really no reason you can find for the child having low-grade fever or infection anywhere. And if a child has a myopathy, you always want to make sure that it's not chronic, slow, or low-grade aspiration that's occurring all the time. Now, remember, the aspiration could be acute, meaning one big bolus of food, either that he swallowed or comes up from the stomach up into the esophagus and into the airway. If it's a huge, large bolus, it may go down into the lung and cause pneumonia. That's one way of presentation. The other is where chronically over time you're aspirating small amounts all the time, but you just cough a little bit or you sound wet a little bit, and then you stop. But even those few drops have gone down into your lungs over time, and with every few hours, they're causing an inflammatory reaction in your lungs and scarring. After, if it goes on for long enough, for a year or so, there's scarring, and once scar forms in the lungs, there's no way that you can get rid of it. So that, in addition to a restricted lung disease, because the child does not have enough muscle power to actually breathe deep, that is kind of a bad combination. So that's the aspiration that we always want to kind of avoid. Anything else? Cliff, Kate, Amy, Shannon, anybody?
Sorry. My daughter doesn't have a trach, but I think there's a couple people on the call who do have kids with trachs, and I just wondered for that part of our community in general, what's different when in terms of GI treatment when a child has a tracheostomy and is on a ventilator.
You mean in terms of swallowing?
Yeah.
And aspiration?
Yeah.
Well, if they're aspirating from above, which means that they're not able to protect their airways, then they will oftentimes, when they're suctioning the tracheostomies, they can actually see secretions, either saliva or even food coming up into the esophagus and going down into the airway, into the trachea, and you can suction that from the tracheostomy sometimes. So you can still aspirate, and even though you're suctioning the tracheostomy tube, you sometimes are not able to suction everything, and some of it can go down into the lungs. So you have to be careful if the kid's having, continuous respiratory issues or just not clearing their secretions, then you should consider that this might be aspiration.
Okay.
When do you recommend using G tubes over the GJ tubes?
So if the stomach is okay and the kid does not have aspiration, he's not an aspiration risk, he's able to have a nice swallow, then but he's not able to take in enough calories and the weight is kind of stabilized or is actually dropping, that's when you would consider a G tube. The GJ tube, typically you cannot put a GJ tube as the first tube. It has to be a G tube that gets converted into a GJ. There are some surgeons that put a straight GJ, but most of the surgeons will first do a G tube and then convert that into a GJ. I'm presuming everybody knows the difference between G and GJ tubes.
Yeah.
Okay, good. So when you have a G tube, the reasons you would do a GJ tube is, one, if you have slow gastric emptying as a result of the fundoplication surgery and that vagus nerve pinching or entrapment, or you have slow gastric emptying as a result of some infection, what we call post-infectious. If you have a slow gastric emptying, then the GJ tube would be a better option than just a G tube, because then you're not feeding into the G, you're feeding into the jejunum farther down. And what you can do in those circumstances is that you vent the G tube, which means that you connect it so that all the air and stuff from the stomach is able to come out through the G port, and then you're feeding through the J port. So you're decompressing the stomach through the G tube port, and you continuously feed through the J tube port. So that you would do when there's a problem with the stomach, as it's slow emptying, and the kid, even with normal emptying, if he's refluxing too much and aspirating, then you should consider doing a GJ tube.
One doctor once told... Oh, go ahead.
Mm-hmm.
Oh, I was going to say, I have a question. Often my daughter will complain it's always when she's eating that her stomach hurts. Mm-hmm. My thought was that perhaps it's not emptying quickly enough, and so she's getting full, because she seems to not complain about it at all after we stop eating. Is this something like, can the stomach stretch? Is this something that can get better over time, and your stomach can get larger and she can be able to eat a little bit larger meals? Right now we're just trying to make sure she has lots of small meals to try to address it, but it seems even with the small meals that sometimes she's still complaining.
Mm-hmm. And how old is she?
She's 8, and it has gotten less and less every year, so I'm hoping that, it is stretching out and that things are getting better over time.
And she's not had a fundoplication, has she?
No, she eats orally, and she doesn't have a G tube or a fundo.
Okay. So it certainly could be, like I said, kids with nemaline myopathy can certainly get other GI conditions, and that slow gastric emptying could be a reason in her case. And there is a test called gastric emptying scan, believe it or not, pretty straightforward. And what you do is the child has to eat 2 scrambled eggs, and they mix the radioactive dye in it, mm-hmm. and they do the study for about 2 to 4 hours, and they see how long it takes for the stomach to empty. Anything above, say, at the end of 2 hours, if typically you and I should be able to empty 60% of what we've eaten from our stomachs. But if at the end of 2 hours there's less than 60% empty, meaning that more than 40% is still in your stomach at the end of 2 hours, that's an indication that your stomach is slow. So that's one way of proving that a child has slow gastric emptying. And if she does, then certainly one of the ways you treat that is small frequent meals like you were saying, and you do a low-fat meal, because remember, fats will slow down your stomach even more. And I'm sure you've experienced that when you have a fat, nice fatty meal or greasy stuff, you just feel blah, and that's essentially because the stomach emptying is slowed down. So you do low-fat, high-protein, high-carb diet, small frequent feeds, and there are medications that can sometimes be used to improve gastric emptying. If it's just a mild case, it does respond, and other times it doesn't. And then there are other endoscopic treatments that we do in kids that have had chronic symptoms that's not getting better. We endoscopically go into the stomach and we inject Botox into the pylorus, which is the exit door leading away from the stomach into the intestines. When you inject Botox there and you stretch it with a balloon, you essentially open up the gates, the exit doors, so that stomach emptying is better. So that sometimes helps with the nausea, but that's usually for more severe cases.
Thank you.
Sure.
I have a maybe related question.
My
daughter is 6 and has a G-tube, but also we've been encouraging her to eat, and she has eaten throughout her life, and we're trying to substitute some of the feed that she would get through her G-tube with the nutrition shake so that she's continuing to experience eating. But with the nutrition shake, she complains of being full, and she'll drink that, over a course of a half hour maybe. But we would, push in a feed or give her a feed at a rate of 250 milliliters over a course of an hour, and she wouldn't complain then. So is there something different if she's drinking it versus if it's going through the G-tube that would cause her to express pain if she drinks it rather than the G-tube? Because other than that, I feel like it might just be behavioral because she doesn't like to drink the shake.
Well, no, there might be a physiologic basis for that too. So if it's the same food that you're giving through the stomach versus mouth, or is it two different things?
Into the G-tube, she's getting Pediasure with fiber, and she's drinking a Pediasure, chocolate Pediasure, a lower calorie dose of chocolate Pediasure. The Pediasure with fiber is 1.5 per mil.
So it could be that even with subtle weakness in her upper esophagus, even though they can drink, it's not to the point where it's causing severe problems, but they're kind of sensing, the body's sensing that discomfort because it's starting to get weak, the upper esophagus, and that's why she's like, the only way she can tell you is that, hey, Mom, I don't want to drink, I'm full, I don't want to. That's kind of avoiding the uncomfortable experience, if you will. So it's like when somebody chokes on food, you know how they get kind of averse to eating those foods, and it's not as severe, but it's kind of in the same realm. And it could be that she's uncomfortable doing it, and that's why she's trying to avoid anything. I'm full, or my belly's hurting, or something, and trying to avoid doing that. That's the only way I can, unless it's behavioral. It certainly could be behavioral as well, but usually kids, why would they not eat by mouth unless there's always some kind of a reason why they're refusing to eat by mouth. Even low aspiration risk, meaning they're not frankly aspirating, but the very, very early signs where the clearance of the back of the throat is not 100%, and it's kind of beginning to kind of, with every swallow, it starts little bit stays back in the back of the throat, and the body's sensing that, and they start to say, okay, this is it, I can't do anymore. So it could be behavioral, certainly, but you need to kind of be aware. Don't try to push it, because her body, again, listen to the body. It's trying to tell us something.
Thanks.
Cliff, you were asking a question?
Yeah, I was once told like bolus feedings help stretch the stomach to make the stomach bigger, which would help with weight gain and being able to feed more at a time. Is there any validity to that?
There is no data to support that, which doesn't mean that it's not true. It's just that we don't have the data to support that. But I mean, continuous gastric feeds versus bolus feeds is just what the child can tolerate. If they can tolerate bolus feeds, obviously we would prefer that. But if they don't tolerate bolus feeds, then obviously you go to GJ to see what the child really can handle. Bolus feeds are preferred only because if they can tolerate, only because that's the natural way we all eat. We don't do continuous stomach feedings. We always eat in, quote unquote boluses. So if he can tolerate boluses, I would recommend just doing bolus. If they can't, then continuous would be way to go. Anything else, anybody?
I have two questions, Malcolm. My son's Sarah. First one, any evidence for probiotics? My son has had C. diff in the past.
Mm-hmm. So, yes, for probiotics, C. diff is one of the conditions in which probiotics has shown to be helpful. Specifically, after the C. diff has been treated, there's a higher recurrence rate. So somebody who's had C. diff once has a higher chance of getting it again. So yes, to give probiotics, you can certainly help with those recurrences. The thing is, which prebiotic? When you talk about prebiotics are of 1,000 different kinds, and you just have to be careful that you use the right one for the right reason. So yes, that's certainly there's data to support that it does help with C. diff recurrences and normalizing your gut flora after you've had a C. diff infection.
Okay, thank you. It's interesting because I work in a hospital, and the doctor recommended it, and IG physicians say there's no evidence, and I feel like maybe they just have
no,
some
there is
interest
evidence
in
for So there is evidence specifically in C. diff infection that certain types of probiotics, as you know, there's different kinds of probiotics, that certain specific probiotics can help reduce the recurrence rate of C. diff if they're given after a C. diff infection. So that's well known.
What are those specific types?
I think Fluorostor is good. Fluorostor and Culturelle?
Well, remember, all the probiotics, there are some that have only one active ingredient. There are others that have a lot of bugs in them. There's 3 or 4 of them of different genus, different varieties. So that whole probiotic field is still, we're still trying to learn more and more from that.
Do you have any brands that you recommend?
Again, it depends on what you're recommending it for. For the C. diff, people typically tend to use Fluorostor. For others, for just a general, like for example, the probiotics that are in yogurt, for example, that's commercially available, the amount of probiotics is really, really low in those. But there are some that are coming out with much higher content, probiotic contents, and hello.
Yes.
Yep.
So it depends on what probiotic you're using for which condition. There's not, like for example, inflammatory bowel disease, folks that have inflammatory bowel disease, they benefit from Fluorostor as well. So, and then there's the VSL number 5. There's another probiotic that they use for inflammatory bowel disease. So, like I said, there's not a lot of data out there about probiotics. It's a good thing, but it doesn't necessarily mean more of a good thing is better. We just have to be careful in what you're using it for and what type of probiotic you're using.
Should you always use a probiotic when you're on an antibiotic? I've heard that, but then we seem to not get that prescribed consistently. So I'm not sure if they're just forgetting or if it's only with some or what the issue is with that.
So there's no consensus on that amongst the pediatricians. What they're doing is, if a kid has had a history of having loose stools every time they have antibiotics, or documented C. diff infection after a course of antibiotics, those are the kids that they will give. Most pediatricians will give a course of probiotics after an antibiotic course. Now the question is, do you give probiotics at the time that you're giving the antibiotic, or do you give it after the antibiotic course completed. And as you can imagine, if you're giving an antibiotic, they could kill the probiotic, the bugs in the probiotic that you're giving him. So what's the point in giving it at the same time? So some pediatricians will start the probiotic after the antibiotic course is completed. Does that make sense?
Yes, that's very helpful. Thank you.
Do you have any recommendations for vitamin supplements? I mean, as you probably know, the vitamins and nutritional supplements are not a well-regulated industry, and I was just wondering if there are any brands that you've heard good things about or that you would feel comfortable recommending.
Honestly, it all depends. We typically would check for vitamin D levels. For example, the things that we check for in our kids periodically is vitamin D for sure, and we like to do it at least once a year. And we also check for iron once every couple of years, make sure that the iron and ferritin is normal, because if that starts to go low, then we have a whole other set of problems. And then also check for vitamin B12 and folic acid. Those are the three vitamins that we check for: folic acid, vitamin B12, and vitamin D. And then if it's low, we will start supplementing. And I will tell you, 9 out of 10 of our kids will have low vitamin D, and that's common in the general population as well. So it's just because of the lifestyle where we are always inside and we're not really getting exposed to the sun. So vitamin D deficiency is very prevalent in our general community, and we have to be doubly careful about our kids with myopathy because they're always mostly inside, or they're covered and don't get enough sunlight. So check vitamin D in your kids once a year at least, and make sure they're adequate. If not, then you supplement them with vitamin D. Now, general vitamins is polyvisol, there's liquid polyvisol, there's some kids like to take Centrum crushed, there's Centrum liquid now too. So really, you just have to be sure that there's not these super vitamins where there's tons, there's 300% of what the body needs or 400% of what the body needs. Those are kind of is not something that I would recommend, because there's always the risk that it may cause hypervitaminosis and cause problems there. You don't have to overdo it, but just regular vitamins, the pediatrician or the dietitian can prescribe for you would be the way to go.
What could they cause for the too much vitamin?
Hypervitaminosis. So, like, for example, if you get too much vitamin D, you can get hypervitaminosis D. You can get high levels of, say, iron if you're taking a vitamin that has a lot of iron in it, and you get iron toxicity. So you just have to be careful that you don't overdo the vitamin thing or the probiotic thing. I have to go. I have another meeting to attend, so if that's okay.
Oh, we appreciate it very much, and this is a very valuable resource you've provided for our community, and we'll definitely circulate it around to all of our members.
And thank you all. It's been a pleasure.
Thank you very much.
Thank you very much. Take care.